brainstem encephalitis.
Say what?
Do you know much about that stuff?
No.
Bickerstaff brainstem encephalitis. Have you heard of it?
Is that like when you bicker with someone and
they hit
makes
you,
crazy?
And they hit you with a staff on the head and you get encephalitic.
Yeah.
That's exactly it. So it was a young woman. She was 15, and she developed somewhat quickly, encephalopathy, and it seemed pretty non-specific. And on examination, she was very confused and not really following commands, and also had sort of motor and ataxic symptoms when assessed later, and also wasn't able to follow finger on extraocular movement testing. So I'm gonna share like a couple of conceptual, I guess, reflections and lessons from the case. But one fun case that Aaron Berkowitz shared is that when someone can't follow your finger and they're confused, it's not clear yet that it is ophthalmoplegia, right? It may be just the inability to follow directions and follow your finger, but the extraocular movements may still be normal. So what Aaron suggested in that case is to always do vestibulo-ocular reflex testing. And if you go like this and the eyes, do move, then the muscles are intact, and otherwise the reflex wouldn't work. So it's not fully ophthalmoplegia. It was just more the cognitive inability. The other thing I like to do, in between, so that's like in a comatose patient, you can take their head and rapidly move it, right? But in a patient who is awake, not following commands, potentially agitated, and you're doing part of a neuro exam, something I like to do is this.
I'm following him with my eyes.
Yep. I don't know if y'all can see, but you can sort of do a lot of, improvisational neuro examination just by moving around and doing certain things and observing the patient. So anyway, I thought that was a nice little distinct pearl. But the other thing I just noticed from the case is that Aaron and a lot of other great teachers, like, Robbie's so good at this too, like, they teach through stories and analogies in an incredibly memorable way, right? So for example, one of the patient also had signs that potentially raised question. She had a headache and she was confused. Raised question for possible increased intracranial pressure. And Aaron talked about how when you eat a big meal, your belly expands, right? When you take a deep breath, your thorax is flexible and it expands. But the skull has prioritized protection over flexibility, right? So anytime you try to put anything extra into it, the pressure can go up very exponentially. And he very simply said, okay, what are the three things that are inside the skull? Brain, blood, CSF. And it's one of those three things that must increase for you to have increased intracranial pressure. And just some of those, I think, again, highly logical, somewhat simplified, anthropomorphized or otherwise kind of narrative ways of teaching, I think are so effective.
I mean, literally what Zavan just described is what one of our mentors in teaching and in medicine said. The three principles of great teaching are: be kind, think out loud, keep it simple. And I think for a lot of reasons, so many teachers in this community very much do that. But I think that simplified kind of algorithm or approach to things is just so the way to go.
Yeah, and so the other example of that within the case discussion that was really helpful for me to learn some neurology that Aaron taught effectively was the idea of a lot of these like related syndromes that we're defining more and more of, right? And I won't do this justice, but Aaron just sort of described it in such a kind of simple narrative way that he said, first we have we had multiple sclerosis. And we noticed that some patients that we think have multiple sclerosis tend to have, a lot of optic neuritis and a lot of transverse myelitis that tends to be sort of very vertical and extensive. And we sort of defined what we thought was a subsyndrome of multiple sclerosis and called it neuromyelitis optica, and found that it was associated with a specific autoantibody that wasn't present in, other phenotypes of multiple sclerosis, the anti-NMO antibody. And then we had the syndrome of NMO. And a lot of times it was antibody positive with this NMO antibody, other times it wasn't. And then we noticed that within the syndrome of neuromyelitis optica, optic neuritis, transverse myelitis, there was a phenotype that was also associated with like ADEM encephalitis. And then later discovered to be associated with anti-MOG antibodies, myelin oligodendrocyte glycoprotein anti-MOG antibodies. And now that seems to be its own disease that is, in a lot of ways different from other NMO. So it's like, it's these syndromes, and then within them we define more and more specifically particular diseases. But just hearing that, like that nested, like it was this, and then we discovered this, and then it was this, helped me sort of conceptualize those three disorders a lot better relative to each other. And then more analogously to this case, the way that the diagnosis came to be, I think it was Matthias. I'm not sure I'm saying the name right, but one of the discussants who did a brilliant job. But they sort of reframed the case and said, if not for the encephalitis, this patient seemed to have ophthalmoplegia and ataxia. If we were to subtract the encephalitis, it kind of seemed like Miller-Fisher syndrome. And that helped Aaron to suddenly realize, wait a second, Miller-Fisher syndrome plus encephalitis, or like, sort of global encephalopathy, is Bickerstaff brainstem encephalitis. And it's a similar sort of analogy of there's Guillain-Barré syndrome, or Guillain-Barré syndrome. The L is actually pronounced apparently. There's Guillain-Barré syndrome. Within it, there's a subset, right, involving ophthalmoplegia called Miller-Fisher syndrome. And then within that phenotype, there seems to be a more specific syndrome, and that's Bickerstaff encephalitis. And in fact, that is associated with an autoantibody as well. Yeah, I think it was really helpful for me to learn those sort of specific examples of kind of nested diseases and associations, but the concept more broadly of teaching about them in that kind of a sort of organized narrative storytelling way, I thought was really cool.
Love it.
That's all.
I think we're good to go here. Ravi is going to discuss, Sammy volunteered to discuss, and Anne-Marie's got a case. We are really excited. Awesome to be back here at VMR. Ravi and then Sammy, do you guys want to introduce yourself? And then we'll turn it over to Anne-Marie to start the case off for us.
Good afternoon. My name is Ravi Patel. I'm calling from India. Here, medical student. I'm excited to be here.
Hi,
Thanks,
I'm Sammy. I'm a last year medical student in Austria at the Medical University in Graz. And yeah, I'm also happy to discuss. I haven't discussed with you guys in a long time. You were actually the first two people with whom I discussed. I don't know if you remember it, but it was nice.
Awesome to have you back, Sammy. Anne-Marie, you want to say hi and kick us off?
Everyone, I'm Anne-Marie. I'm a hospitalist, and I'm so excited to hear Ravi and Sammy discuss with Zavan and stuff today. I know it's going to be an absolute treat. This is a pretty simple case, but I think there's some fun discussion, and I don't have the full case. It was a case I saw and then later tuned into a
morning report, and I was like, oh, I remember seeing that case. And so I jotted down some details, but I apologize if there's a few specifics I can't answer, and then I'll change, of course, some identifying information. So this is a case of a 45-year-old male who was sent to the emergency department by the endocrinologist for lab abnormalities. I'll keep those lab abnormalities for now, just to kind of create some suspense. So 1 month earlier, the patient had gone to the beach with his family and had cut his feet on some shells while walking. And then a week after that, presented to urgent care with concern for infected wounds on the feet and legs. At that point, he was prescribed TMP and SMX. And about a week after that, the wounds had mostly resolved, but he felt a little feverish, some chills, myalgias, nausea, vomiting, malaise, fatigue, and headache. At that point, he was tested for COVID-19, but was negative. His wife also had noted some similar symptoms. And then he just went home and had some supportive care. And then later went to his endocrinologist, who had obtained some lab work and told the patient to come to the ED despite the other symptoms being improved. Additionally, on review of systems, there was no respiratory symptoms, no chest pain, no abdominal pain, no diarrhea, and no rash. Relevant history includes a history of hypertension, diabetes, and hyperlipidemia. And I'll just leave it there.
Awesome. And then I think, Kelly, you're scribing. Do you mind zooming in the screen just so the text is a little bigger? Thanks so much. Zavin and Ravi, do you guys want to kick it off?
Sure. Can I just ask one follow-up question, Anne-Marie, before Ravi takes this away? Why I missed this? Why did he go to the endocrinologist? This was just a schedule
for routine diabetes management.
Thank you.
Thank you. So good information. So we have 45-year-old male is presented to emergency department. So 1 month prior to our hospital, he had a cut. So given the history of diabetes, so I'm thinking of, is it diabetic foot ulcer are causing infection and spreading? As we know, in terms of poorly controlled diabetes management, patients usually have like high blood sugars in their blood vessels, and that predisposes to develop infection, such as necrotizing fasciitis, cellulitis, and ulcers, because these patients have a predisposing condition. Most of the patients have a neuropathy, they have decreased sensation, and they can't feel their feet. That's what we recommend follow up with the podiatrist. So he had a concern for infective wound on feet and legs, and he was treated with Bactrim. So the wound has resolved, but however, he felt like feverish chills and myalgia. So I'm concerned about bacteremia at this moment because he has chills and feverish. So later he went back to endocrinologist, probably he just stated diabetes management. So he may be insulin dependent. We will have more information later. So my thought process right now, what are these lab abnormalities? Could be like DKA, high glucose, thyroid dysfunction. It could be adrenal insufficiency. When someone has like an adrenal tumor, a cortisol release, having cortisol release he may develop like a tumor in the adrenal gland, causing diabetes that could cause complications such as wound. Thank you.
Thanks, Ravi. Awesome job. I was trying to think like in real life, say I'm the endocrinologist. Is this the history in the last month? Like, is there anything more to do about it, honestly? And I guess I'll ask Anne-Marie to clarify, like, are these symptoms that he and his wife had on their way down now? Are they getting better? Like the headache, malaise, fatigue, myalgias?
Yeah, they had actually resolved by the time
They
he
had
went
resolved.
to the endocrinologist.
Okay. And because these symptoms do sound viral, and because his wife had them too, whether COVID or not, they probably aren't necessarily related to the cut on the foot. So it seems like he's just had a bad month. Okay. Right. Like right now, it just seems like he had this cut, he got treated for the wound. It got better. Thank goodness. And then he had this virus that's getting better. Thank goodness. Now he's here, routine follow-up. So, I wouldn't necessarily I don't know if there's much more to do on this, right? Like the endocrinologist must have checked whatever labs he's going to check. And it was probably a surprise, the lab abnormalities that were found, and we'll see what those are. And we'll tackle those, when we see them. But just realistically, it seems like this prior history, is what it is. Now, I do want to comment. I saw pop up in the chat, Valeria mentioned that when she hears, walking on the beach and soft tissue infection, she thinks of Vibrio vulnificus, and you absolutely should. And especially, in people who either have known liver disease or may have subclinical underlying liver disease, such as, 20% of the population, especially somebody with metabolic syndrome, is very liable to have some non-alcoholic steatohepatitis, possible early subclinical cirrhosis. And the stakes for not treating a Vibrio infection in a patient like that are very high. People can get very fulminantly sick who have liver disease and either have gastrointestinally introduced Vibrio or soft tissue externally introduced Vibrio. So in this patient, I probably would have chosen levofloxacin with Bactrim to not only cover staph, but also Vibrio, as well as, strep maybe a little bit better and gram-negatives a little bit better, given, if you frame this as a diabetic foot infection, right? But it seems like we got lucky and the patient got better. So that's kind of all I'll add at this point, and really curious to see how this patient looks, and certainly to hear what this lab abnormality is.
Awesome. So as far as further history, social history, occasional alcohol use socially, about like 2 beers per week, but no significant alcohol use, no other tobacco or street drug use. Family history was only like that. There was some family history of elevated like bilirubin on labs, but no formal diagnosis. And then surgical history had a prior appendectomy. Medications included aspirin, carvedilol. I always mispronounce this, but gliflozin, I can never say it. 12.5 twice daily, which had been added about 2 weeks ago. Metformin, lisinopril, pantoprazole, semaglutide, simvastatin, Tresiba nightly, and then was finishing up the TMP SMX. So it was prescribed a 14-day course of that. And then the abnormality that was sent in when was liver enzymes in the thousands. I don't have the exact vital signs, but the heart rate was regular, not on oxygen with a normal pulse ox, a normal blood pressure, and respiratory rate. Generally appeared comfortable and in no acute distress. Otherwise, cardiovascular exam was normal with a normal rate, no murmurs heard. Pulmonary exam, the lungs were clear. Abdominal exam, there was no significant tenderness to palpation. Bowel sounds were active. No hepatomegaly or splenomegaly was felt. On skin exam, the wounds on the feet appeared well healed. There was no surrounding erythema or tenderness to palpation. And then there was good blood flow distally. And then on neuro exam was alert and oriented, no asterixis, no tremor or other abnormalities. And then do you want the labs, or do you want to discuss this information first?
I guess we know about the high AST/ALT. Was there other, I think we can work with that unless there was other data coming in the door that we would have seen if we were admitting him.
I think that was the most relevant data. It's just the very high AST and ALT.
Thank you. All right, Sammy, what do you think?
Wow, okay, that's a lot of information. First, when I had heard the first alloquat of the endocrinologist stepping on the shells, I immediately thought of hypogonadotropal hypogonadism in hereditary hemochromatosis and associated with Vibrio vulnificus, but because the wounds got better and he looks stable now, I don't think that this was the causative bacteria, but that was just a quick thought also with the diabetes in the past medical history. For the medications, so I think we have the foreground and the background. The foreground are those elevated liver enzymes, and the background is this feverish episode, all those medications, this family history of the elevated bilirubin on labs. It's good that the patient is stable and that his exam is actually benign. Anne-Marie, I have a question. Was he jaundiced or not?
There was actually no jaundice, no scleral icterus that could be seen. If you used your imagination, you could maybe see a little bit of yellowing at the base of the tongue, but certainly not obvious.
Okay, perfect. Thank you. Yeah, when I think about LFTs or liver injury in the first place, I always think, is there some stigmata of chronic liver disease on the skin, like pulmonary erythema, caput medusae, stuff like that? Here we don't see it, so it makes it less likely, but it certainly doesn't rule it out. But I would step a little bit more away from maybe cirrhosis and decompensated chronic liver disease and maybe think about a more acute process. And when we have LFTs in the thousands, I think first off, medication toxicity, especially paracetamol, it's called in Austria, yeah. Then I think about ischemia. He doesn't seem cardiovascular unstable. His heart rate is within normal limits, his blood pressure, which makes this also a little bit less likely. I would still be concerned about hepatic vein obstruction, maybe Budd-Chiari syndrome, but he doesn't have hepatomegaly, no tension pain of the hepatic capsule, which maybe also renders it a little bit less likely. Then I also think about acute viral hepatitis and also other causes of acute hepatitis like leptospirosis or other herpes viruses. I don't know if the association with the shell could maybe first be a viral prodrome and then the decompensation of the hepatitis with some hepatotrope virus. We definitely get hepatitis serologies. And I'm also thinking about autoimmune hepatitis, which can present that acutely, I think. is certainly on the differential. 45-year-old man could be possible. I associate it much more with females, but could certainly be possible. And for the last thing, I also want to mention Wilson's disease, which can present with fulminant liver failure, would be much more typical in a 50-year-old guy or 45-year-old without any other stigmata. Interested in the hemoglobin anemia would help us a little bit. Yeah, those are my first thoughts.
Wow, your first thoughts are the spot on perfect thought, Sammy. That was just a beautiful summary of the fairly limited set of categories of conditions that can kill off or inflame thousands of hepatocytes at the same time. And you did just a really nice job hitting all of those major categories. And I'll just summarize for the group. You mentioned viral hepatitis, and that includes not just our typical hepatitis A, B, C, D, E viruses, but also others like CMV, EBV, HSV. You mentioned toxins in general. Tylenol, of course. This is now maybe a piece of history we wouldn't have gotten from him naturally or have thought to ask is when he was feeling crummy with these fevers and chills and his feet were hurting from the cuts, perhaps, how was he taking any Tylenol? I feel like Tylenol history, I'm not in the habit of sort of asking that explicitly unless a lab or something else is flagging me. So Tylenol, AKA paracetamol, AKA acetaminophen is very important to think about here. And then I think we'll have to come back to, are there other medications that he's on that put him at risk for drug-induced liver injury also? So we talked about viral hepatitis, toxin or drug-induced hepatitis, of which Wilson's falls in that category because it's copper toxicity. And then you mentioned autoimmune hepatitis, problems with impaired liver perfusion, whether overt hypotension on the arterial side causing shock liver, or you mentioned Budd-Chiari, sudden venous backflow can do the same. And then the final category is acute biliary obstruction can initially present with a hepatocellular pattern instead of cholestatic. But a striking negative here, and here's when I want to tie in some of the beautiful history that you picked out, Sammy, is he didn't have any abdominal pain. And that would be very, very surprising, right, for him to have biliary obstruction without abdominal pain. So that really falls down the list. And I just want to say, Sammy, I really like how you kind of had a differential diagnosis and you went back and tied it in with the history. I completely agree. His generally feeling feverish and unwell, could that have been the beginning of an infectious viral hepatitis? Quite possible. It could be very nonspecific without abdominal pain, but with the upper GI symptoms of nausea, vomiting, fevers. So that is really a great thought. I like that you tied in the family history of the elevated bilirubins. It's worth just putting a flag on, particularly for the autoimmune category that you mentioned. And then the medications, I think, as I mentioned before, we need to come back to. Sammy, of all the stuff he's on and has been on recently, does anything stand out to you that could be a risk for drug-induced liver injury?
Yeah, of course, the trimsulfa comes to mind, which has a high likelihood of drug-induced hepatitis.
Yeah.
And can I just add one more thing?
Please.
One more thing that just came to mind. There's this rare entity, I think, that's called glycogenic hepatopathy, which is been seen in type 1 diabetes, where you can also have AST and ALT elevations. That's also a thing that you can maybe think about. It's really rare, I think, and only with badly controlled diabetes mellitus type 1. But just maybe something to throw in.
Yeah, great point, given his past medical history. I completely agree. We have to worry about the antibiotic. The recent introduction of the SGLT2 inhibitor, I think we'll have to be careful about. And we've mentioned before, anytime you're worried about drug-induced liver injury, the online resource of Liver Tox being a very, very good resource to figure out which of all these meds he's on is particularly high risk other than those two new ones. I want to stop there. The only other point I want to make is normal mental status and lack of asterixis on exam can let us take a bit of a sigh of relief. It's very unnerving for the patient and the team of physicians to see the AST and ALT in the thousands. There's no doubt, right? He has acute liver injury. But as far as we know, chatting with him and meeting him, he's not in the category of acute liver failure yet, which is really defined by liver injury plus encephalopathy and coagulopathy. Now, we haven't gotten all of his labs yet, but the fact that he could do a really detailed history with us, has a normal neurologic and mental status exam, is hopefully reassuring that while his liver is quite injured, it is not failing at this time, but it's something we'll have to watch for closely. We can turn it back to you, Anne-Marie.
Awesome. So COVID and influenza testing was again negative. On CBC, the WBC was 4.1 with mild lymphopenia to 1. Hemoglobin was 14.9 and platelets were 256. On the complete metabolic panel, the sodium was 140. The potassium was 4.1. The chloride was 101. The bicarbonate was 30. The BUN was 18. And the creatinine was 0.6. The glucose was 103. There was a normal anion gap of 9. The calcium was 9.2. The albumin was 3.9. And the total protein was 7.2. The total bilirubin was 1.8. And then the AST was 1,222. And the ALT was 2,325 with an alkaline phosphatase level of 121. And I do not have kind of the past liver function tests, but I think they'd been normal to mildly elevated AST and ALT in the past.
Thank you so much for the information. So I just want to add on to the physical examination. The good news is that the wound on the feet appears well healed and there's no surrounding erythema. So given that he had a history of wound, now the wound has healed, so that's good news. Going to the hematology, white count is 4.1 and hemoglobin is 14.9 and platelet counts at 256. I'm thinking like we had a lot of differential diagnosis that Sammy had described to us. So I'm trying to like rule in and rule out like hemochromatosis. He's mentioned, he said viral hepatitis. So I'm trying to like which one causes anemia. So he doesn't have anemia like 14.9. So there's no anemia of chronic disease. So I'm trying to like see which one like falls. I'm trying to like basically prioritizing which differential diagnosis goes up and down. Hopefully we'll have more information. So in the chemistry laboratory data, creatinine is normal, sodium, potassium, and bicarb. And glucose is good, actually. Glucose is 103, even though he has a history of diabetes, he's non-insulin dependent. His iron gap is 9, so he's not DKA. So going to our attention, we're going to pay attention to AST and ALT, and alk phos is normal. AST is 1,222. Alk phos is, ALT is 2,325. So the ratio between AST to ALT, so he doesn't, in the social history, he has only occasional alcohol use, 2 beers per week, but that usually, alcohol intake usually increases AST compared to ALT. In his case, ALT is higher. So that is telling me that either viral hepatitis could be consideration. This pattern seems like a hepatocellular pattern. Bilirubin is 1.8. So I'm trying to like right now which which differential diagnosis should be higher on the list in terms of the list of the conditions which cause liver injury. Is it autoimmune? I guess we need to do more laboratory data. It's hard to tell. Thank you.
Ravi, I'm like right there with you in the, in the struggle to make any further progress in the case beyond the beautiful comprehensive differential that Sammy and Steph laid out for this kind of massive, as you said, pretty purely hepatocellular, right, liver injury. We really haven't gotten any extra information. Like what we need is viral hepatitis studies, right? What we need is imaging, including of the vasculature. What we need is basically testing for the differential diagnosis that's been mentioned. So I guess what can we kind of think about and learn from these labs? I think a couple of sort of peripheral teaching points that go back to some of the earlier aliquots too. So one is, if this, just a pearl about Budd-Chiari syndrome that I just learned recently from doing MKSAP questions. So if we do get a right quadrant ultrasound with Dopplers and there is a hepatic vein clot, first of all, we will be a little bit surprised because, again, there was no pain and no kind of ascites. But that hemoglobin of 14.9 stands out a little bit to me in somebody who, has some chronic conditions, but also has had, as we mentioned, a pretty rough month, right? And what I learned from the question is that even in the absence of overt polycythemia, when you have hepatic vein or other visceral thromboses, half of those are caused by myeloproliferative disorders, and you're supposed to check for JAK2 mutations, even if there's no clear overt, polycythemia. So
just part of the hypercoagulable
it's just part of the workup for hypercoagulability when you have a visceral thrombosis like that. And then going back to this, mystery of ooh, what electrolyte is this going to be, right? I can't help but notice just how many possible electrolyte lab abnormalities there could have been, right? And I think just as high yield kind of factual teaching points for everybody, this was probably mentioned in the chat, but we have to know that Bactrim can cause hyperkalemia, right? That trimethoprim is structurally similar to triamterene, which is one of our potassium-sparing diuretics and inhibitors of the ENaC channel. So especially when your patient is on lisinopril, spironolactone, which this patient is on, you have to be really careful, choose an alternate agent if needed, if the baseline renal function isn't great, so that could have been easily one of them. Bob Centaur always makes the point that just sick people make ADH, right? And sick people, generally maybe drink a little more water than they eat food. So we shouldn't have been surprised if this patient had become hyponatremic. You cut your foot, you have a wound, it hurts to walk, you don't walk much. You're feeling wiped out, you have COVID, you're laying around in bed. There was a great case of hypocalcemia of immobilization recently in a patient who just had bilateral cataract, sequential cataract surgery, and was effectively blind for a couple of weeks and didn't move around and got a calcium of 15.
Wow.
Which self-resolved once the patient moved around again. Euglycemic DKA is a complication of SGLT2 inhibitors that could have happened. The interaction of multiple new medications introduced with the simvastatin could have potentially caused rhabdomyolysis, which, to come full circle to the differential diagnosis of massive ALT, AST elevations, rhabdo is definitely on the list. Okay, so the highest ALTs I have ever seen have been from rhabdomyolysis. Skeletal muscle contains both AST and ALT. the ratio of AST is much, much higher, about 4-to-1. So when you first, if I like crush my quad right now, my AST might be 10,000, my ALT might be 2,000 or 3,000, okay? But here's the other key point. The half-life of AST is much, much, much shorter. So if I crush my quad and then stop crushing it and the injury stops, 2 days later, my AST might have come down much, much more than the ALT, such that there might be a cross-section of time where the ALT is actually greater than the AST. So in this patient, especially with the viral prodrome, especially with the Symphony and the other drugs, I think helpful would have been to ask about any dark urine, that even in the absence of this bilirubinemia, if there had been, discoloration of the urine, you might have, and, just ultimately check a CK. It's easy enough to rule that out and be done with it. A quick point here, if you got a urinalysis at this point where the ALT is greater than the AST, it might be negative too. The myoglobin also has a short half-life, and that's what triggers the blood assay on the UA. So even if this was missed rhabdo from 3 days ago, the UA now may actually be normal. But again, in the context of everything, I think probably less likely, but certainly always think of skeletal muscle as a source of even very high AST, ALT, especially when the AST is higher than the ALT.
Awesome. So on further kind of history from the patient at the beach, he did have oysters, denies other exposures other than what was discussed. And he had taken a little bit of ibuprofen and Tylenol during the injury, but none during the past week. And upon review, not a significant amount, definitely less than 2 grams per day when he was taking it. And so you get some further lab data to try to figure out what's going on. First, you get a direct bilirubin, which is actually normal. And then a CK is also normal as well. Tylenol level is undetectable. LDH is 1,100 with a normal haptoglobin level. Ultrasound of the liver with Doppler showed patent vasculature with normal flow, but with a heterogeneous liver that could be seen in some chronic liver disease. No signs of cholecystitis, no sludge, normal common bile duct diameter. And then a repeat hemoglobin A1C was 8.4. TSH was within the normal range. INR is 1. ANA is slightly positive at 1 to 80. HIV is negative, and then you are waiting on that hepatitis panel to come back still. So kind of up to this point, kind of any other concerns or anything else that we should be thinking of?
What do you think, Sammy, based on the great set of possibilities you came up with? Where are we?
Okay, that's a really interesting case. So I think we've excluded basically ischemia. We've excluded Wilson's disease or made it less likely. Also rhabdomyolysis, which I didn't know can cause AST and ALT elevations that high, is basically or is made less likely with the normal CK and the normal creatinine, although Zaven, you said it could be normal after this time, but maybe he would have more muscle aches and stuff. But also gallstones are excluded, so I think we stay with hepatitis, we stay with hepatotropic viruses. There's still a possibility of autoimmune hepatitis. He has an ANA of 1 to 80. There is no protein gap, which would also be highly characteristic of autoimmune hepatitis, but also of acute hepatitis from the hepatitis viruses. And also on the last on the list is still METs, the tremosulfa that could maybe have triggered this hepatocellular liver damage. Yeah, the LDH of 1,100 is not surprising in comparison to those highly elevated LFTs. So yeah, I would really be curious what the hepatitis serology showed. I think A and E are transmitted. You have to eat it. So fecal oral, or yeah, and B, C, and D basically IV or through sexual behavior. And maybe he could have acquired acute hepatitis A eating the oysters. I don't know if Vibrio is still on the table. I think he would be much sicker. But we could get the ferritin and transferrin saturation to maybe elaborate on that, but it could be falsely high in the setting of inflammation, the ferritin. Yeah, Steph, what do you think?
I think I totally agree with above. That was stellar, Sammy. I really don't have too much to add at all. Anne-Marie, what do you got for us?
Yeah, so we discussed with hepatology, and I honestly, since I don't have these full records anymore, forgot whether or not we started in acetylcysteine. I think we might have. We stopped the simvastatin as well as the TMP and SMX upon admission, closely monitored repeated liver enzymes, which started downtrending. Patient continued to do well with preserved synthetic function. And so we decided to discharge while holding the statin, as well as adding TMP and SMX to the medication list. Later, the hepatitis panel came back negative. And then the patient followed up with hepatology, and they actually repeated viral hepatitis testing, which was again negative at that time. And then the liver enzymes were repeated and had almost completely resolved, but still with just a mild AST to ALT elevation in the hundreds. And so it was thought that the most likely etiology was drug-induced liver injury, secondary to TMP and SMX in this case, just given the kind of the time course, the lack of a viral precipitant. We had reviewed kind of records and asked the patient like about hypotension. There was no hypotension. There was no signs of volume overload or heart failure that would be concerning for developing like an ischemic liver injury. And also the LDH to AST ratio made us think that that was less likely. And so thankfully the patient did well. I think that probably there was some underlying liver disease from the diabetes that probably precipitated this. And then the bilirubin remained just mildly elevated, but it was an indirect that seemed consistent with Gilbert's. We didn't see any other signs of hemolysis, and we felt like the LDH was likely secondary to liver injury and not due to hemolysis. I thought this was interesting because I think I knew that TMP and SMX could cause liver injury, but I didn't realize that it's within the top 5 to 10 causes of drug-induced acute liver failure. And it can often cause this like idiosyncratic liver injury. So I thought this was just interesting because I don't know if I realized kind of how common this could be.
Wow. Great case, Anne-Marie. I might have missed it. Were any of the diabetes medications implicated in possible drug-induced liver injury for him?
Yeah, so we had looked those up on Liver Talks, and I think I misspoke earlier. Sorry, I wasn't planning to present the case. The new medication that had been started was actually the semaglutide, and we initially held it, but we looked it up on Liver Talks, and there was actually no reported cases of that being associated with liver injury. And so we ended up restarting it upon discharge.
Thank you. Great case, Ravi and Sammy. What a stellar discussion. I think were you guys the team taking care of this patient, he would have been managed extremely well. So congratulations. Any final thoughts or reflections?
No, just a great lesson with the Bactrim. Had a similar case with Keppra actually, but drug-induced liver injury is always challenging because it's a diagnosis of exclusion, right? And as with all diagnoses of exclusion, the journey has to be a little bit, involved.
I
Thank-
really thought it was going to be hepatitis A with a history of oysters and the time course and having another sick family member. I was actually kind of surprised when it wasn't, but I think sometimes it's an interesting diagnostic journey, but maybe here the lack of that significant protein gap maybe could have helped a little bit with that. But with a lymphopenia too, I just was like, oh, this is hepatitis A.
Yes, totally agree. Just that story, right, of his wife going through the same illness was quite a good setup for foodborne illness.
And he was tested for E also.
Oh, sorry. I don't think that we ended up testing for hepatitis E, considering the lack of travel. It was all kind of within the Eastern United States. No history of like travel to another country or anything like that. So I don't have that in front of me, but I don't think that we tested for hepatitis E.
Cool. Thank you. Thanks so much, everybody, for joining, and to Anne-Marie and Sammy and Ravi for discussing with us. Have a great week, great month, and we'll see you next time.
Thanks, guys. Take care.